Okay, so a pleasant day to all. It's 3 p.m. So we'll be starting the first pocket meeting of the Fragility Fracture Network for the year 2021. On behalf of the FFN Regionalization Committee, the Fragility Fracture Network Philippines, I would like to welcome you all to the first Asia Pacific pocket meeting for the year 2021. Just to give you a brief background, the FFN Regionalization Committee started the pocket meetings last year, which was hosted by FFN Malaysia, which was also the year's host for the virtual experts meeting. It was originally intended to engage and to sort of get updates about the situation of the other national FFNs, especially during the time of the pandemic. This year, we decided to broaden the participation and open up the meeting to everyone who is interested in learning the holistic management of fragility fractures. So similar pocket meetings will be held in the European and Latin American regions. This will be the first in a series of 3 pocket meetings. Each meeting will focus on the 3 clinical pillars of the global call to action. Today, we are collaborating with the Secondary Fracture Prevention Special Interest Group of the FFN. The second pocket meeting will be held sometime in July in collaboration with the Hip Fracture Audit Special Interest Group. And the third pocket meeting will be held in August in collaboration with the Fracture Recovery Special Interest Group. This will lead up to the combined FFN pre-Congress regional meeting and Global Congress on September 28 to 30, 2021. Before I end my welcome remarks, I would like to thank the committee members of the Fragility Fracture Network Philippines, the Asia Pacific Program Committee members, as well as the UPPGH Department of Orthopedics, who is celebrating our 50th founding anniversary. They helped us very much in setting up this event. Okay, so with the help of our chairman, Dr. Juanito Javier. With this, I would enjoin you to listen carefully and to react in this meeting. We want this to be a sort of interactive meeting. Okay, and I would like to turn the screen over to the founding president and the current regionalization chair of the Fragility Fracture Network, Professor David Marsh, for some updates about what's happening with the global FFN. Dave?
Thanks very much, Owen, and congratulations to the team that you mentioned for putting this together. Great. Well, as Owen says, I just want to tell you what's happening around the world from the point of view of the global FFN. And the first thing to say is, as Owen's already mentioned, that what is happening here in Asia Pacific is being echoed in Europe and Latin America. And there will be also a pocket meeting in North America. But in Europe and Latin America, there will be 3 pocket meetings like there are going to be in Asia Pacific, and they will lead up to a pre-Congress regional meeting, which will be the day before the Global Congress so that'll be on the 28th of September, and the Global Congress is 29-30, and people will register for the whole event. So they will get their regional meeting, and the day after that, they will join the Global Congress. And if any of the sessions in the Global Congress happen to take place at a time when you can't make it, we will have all the sessions recorded and available on demand. The next thing I want to tell you about is the Global Guides to Action. And this is our website there, fragilityfracturenetwork.org. And all these documents that I'm going to mention are free to download. And then I want to mention some of the education initiatives and our memorandum of understanding with the International Osteoporosis Foundation. Next slide, please. So the first of these guides to action are toolkits, which were funded by a grant from UCB, although we had full editorial control. They were launched last year in the European Regional Expert Meeting. And as you can see, they've been translated into several languages. Basically, there are 2 of them. The clinical one tells you how to set up the 2 major service developments that one needs, and that is orthogeriatric co-management of pillars 1 and 2, the acute phase and the rehabilitation, and for fracture liaison services for pillar number 3, secondary prevention. The policy toolkit is all about how to bring about persuasion and policy change that facilitates these changes. So it tells you how to persuade your colleagues, the health service managers, and the politicians. Next slide, please. So in the clinical toolkit, with the 3 pillars with which you're going to become very familiar, it gives you all the evidence you need to prove that they're clinically effective and cost effective. It tells you how to map your current pathways and how to stepwise implement an improved pathway. It also talks about benchmarking, particularly registries, particularly of hip fracture registries that are going to be discussed in the second of your pocket meetings, how to involve the patients and what resources you will need. Next slide, please. The 4th pillar of the FFN's philosophy is the engagement with politicians and managers to bring about policy change. And this toolkit is dedicated to that, giving guidance on how to engage with the necessary parties successfully. It gives a lot of useful templates, job descriptions and things like that, guidelines, consensus guidelines, etc. And it gives a lot of case studies which should give you great ideas about how to proceed in your country. The next thing is this orthogeriatrics book, which tells you everything you need to know about the post-fracture pathway. This is the 2nd edition, and it is free to download. And actually, it's now 200,000 downloads we've had of chapters. And again, this is being translated into several different languages. If you're interested in forming a national FFN, or if you've got one and you want to develop it, then you need this document, again, downloadable, why we need them, how to set them up and how they work best, and what exactly is their role, and how can they engage with the challenges of improving clinical services and bringing about necessary positive healthcare policy improvement. The Education Committee of FFN is very active because we realise that as we deal with the pandemic of fragility fractures, there's going to be a need for change of service configuration and change of people's roles. So we've already got these the ones that I mentioned, but there is also a book on fragility fracture nursing and one coming out soon on nutrition. Again, they're all going to be translated into several languages, not necessarily yours, I'm afraid. But if you want to translate them, then you can do so without any problem, because we own the copyright for all these publications. But the big challenge over the world is how to teach orthogeriatric competencies to other physicians or other healthcare professionals in countries where geriatricians are thin on the ground. Because the philosophy, the geriatric competencies that are needed everywhere to look after older patients with fragility fractures, but they can be learned and absorbed and applied by people other than card-carrying geriatricians. And so there's a big collaboration between the Education Committee and the Regionalisation Committee and the national FFNs to do that. And the same applies to FLS nurses. Today's meeting is a beginning of how to develop the workforce in your region to provide the necessary staff to deliver secondary prevention universally to all fragility fractures in all countries. We hope that the orthogeriatric training will be enhanced by a fellowship project that we're planning, and we're also recognising the great importance of caregivers. When patients go home, or if there are very few allied health professionals available, then family members are going to be, we're going to have to rely on family members. And they need to be educated, and it's been shown clearly that the well-being and the health even of caregivers and that of the patients that they're giving care to are interdependent. So it's very important to train up the caregivers, and we're doing that with a web-based educational project. The same thing applies to nutrition. This needs to be understood by everybody, not just nutritionists, and so we're doing an educational project about that. Finally, I want to mention that we signed a memorandum of understanding with the IOF last year. They respect our expertise in the acute management after fracture, and we respect their expertise in primary prevention, which is not really the business of the FFN. But we share completely common ground on secondary prevention, the need for fracture liaison services and the role of the Capture the Fracture campaign. So we always offer IOF input to our meetings so that they can give us the benefit of their perspective on secondary prevention. And one example is that in Europe, there is an FLS Academy and network that's been set up with co-chairs, one from IOF and one from FFN. So that's a quick run through of what's happening on the global level with FFN, and I'd just now like to wish you all the best for this regional meeting, which looks as if it's going to be fantastic. Thank you very much.
Hey, thank you, Dave. Thank you for giving those updates. So there are exciting things happening, you know, with the global FFN. So now we will start the keynote presentations. I would like to introduce our keynote speakers for today. Our first keynote speaker is the head of the rheumatology at Sydney's Royal North Shores Hospital and the Liaison Professor of Rheumatology and Musculoskeletal Epidemiology at Sydney University. She plays a major international role in the measurement of global burden of disease and patient-reported outcomes. She was the inaugural treasurer of the Fragility Fracture Network, a board member for the first 4 years, and established the FFN Vertebral Fragility Fractures Special Interest Group. She led the New South Wales Agency for Clinical Innovation MSK network that developed the osteoporosis refracture prevention model of care, and which we will discuss today. She is an executive member of the GMUSC, the Global Musculoskeletal Alliance, that is working to have MSK bone and joint health prioritized by WHO and national governments worldwide. It's my pleasure to present to you our first keynote speaker, Professor Lynn March. Hi, Lynn.
Hello, Owen. Thank you very much. And I think Robin's going to start sharing our slides and also lead off. Thank you. Hi, everyone.
Hi, Lynn. I also introduce our second keynote speaker. She is a registered nurse with a focus in the past 30 years on chronic condition care in outpatient and community settings. During her clinical career, she became one of Australia's first nurse practitioners. Since 2009, she has supported the development, implementation, and evaluation of models of care for the Australian state of New South Wales related to refracture prevention, osteoarthritis, low back pain, and juvenile arthritis. Importantly, the model of care for osteoporotic refracture prevention has now become a part of the New South Wales health policy. That means all residents in New South Wales have access to refracture prevention services. She currently holds positions with the Global FFN, the WHO, Sydney University, New South Wales Electronic Medical Records Development Organization, eHealth, New South Wales, and the Consumer Organization Arthritis of New South Wales. Also, it's my pleasure to introduce Robin Spearin. Hello, good afternoon, Robin.
Good afternoon, everybody. Good to be here.
Okay.
Thank you, Owen.
I would also like to introduce later on, we will be joined by two, nurses who also promotes the advocate of fragility fracture care for geriatric patients. The first is an FLS expert nurse from Hong Kong. He practices at Queen Elizabeth Hospital. He's none other than Chang Kakit.
Hello. Hello, everyone. Thank you.
And also from the Philippines, he's a board member of the Gerontology Nurses Association of the Philippines, a gerontology expert nurse, and also an advocate of geriatrics, Dr. Elegio Razalan. Gio?
Hello. Good afternoon.
Okay, good afternoon, and thanks to everyone. Okay, and now I will pass on the screen for the presentations of our keynote speakers. Robin, Lynn.
All right, so thank you, Owen, and the rest of the team for inviting us to present some of the work that's being done around secondary fracture prevention over the last few years with the FFN. So I'm here representing the Special Interest Group for Secondary Fragility Fracture Prevention of the FFN, and my advisory group has had input to what we're going to talk about today. So we're going to primarily focus on the example that we've had in New South Wales, but of course the evidence is international. But it's just going to give you some understanding of what it is that we've done in getting to the point of where it's normal business now in New South Wales to provide fragility fracture prevention services. So the aim that we have today is to support the development of the workforce in your region in support of the WHO Decade of Healthy Ageing. So we're going to do that by discussing some of the evidence around secondary fragility fracture prevention, presenting the case for multidisciplinary services. We want to challenge you all on how to overcome obstacles that you may have based on what we're presenting, and then of course linking that to the WHO aspirations. I have to say that what we're presenting today is what could or should be best patient outcomes, should be provided for best patient outcomes. So we're not really reflecting on what COVID has done to us all, though we recognise the challenges we all have to consider. And I know that that will come up later on with our nurse responses. So this is the way it should be. And then we have to add on that layer that you can utilise locally for in consideration of COVID. So I'd like to hand over to Lynn now to talk about some of the evidence that we use in promoting these secondary fracture prevention services. Thanks, Lynn.
Thanks very much, Robin, and thanks, Erwin, for inviting me to speak, and congratulations on organising a conference on this very important topic. And I guess send greetings to you all from Australia, but also greetings to those who might be celebrating Ramadan this month. Just by way of background, as things over the last, since the 21st century, just putting things into context, the WHO started measuring burden of disease, and the first set of burden estimates focused mainly on diseases that caused mortality, and the musculoskeletal diseases weren't particularly well represented. Then in around 2010, you know, after that first decade, that was actually the decade of the bone and joint decade, quite a lot of work was going on, including with people, with Dave Marsh looking at the orthopedic components of musculoskeletal diseases. And actually the FFN was born out of that bone and joint decade. But the next 10 years, we've sort of focused on the burden estimates. And now, although osteoporosis is not included as a disease, low bone density was included for the first time as a risk factor for morbidity and mortality from falls and road traffic accidents and other injuries. So what the WHO started noticing was that non-communicable diseases were having a big rise as the population was aging. More and more people were living long enough to get their fragility fractures. And I guess there may well be a switch back as we see the, you know, the enormous and distressing impact that COVID has had, and many resources, as we've noted, needed to have been directed in that way. But as things were evolving, aging population, lots more chronic disease, then the focus began to shift to measuring quality of life, quality of healthcare. So outcomes were more sort of care-based and outcome-based. And that concept was developed by Porter and others, and Robin's very carefully prepared these slides and has references at the bottom for you to access and read up a little bit more about. But this came out of the Harvard Business School, and there's an international group now called ICHOM, the International Collaboration for Health Outcome Measures, where they're looking at measuring care by the value that people get from the care, not necessarily by numbers and throughput and saving lives, more about actually improving value-based care. And it's not just about an enhanced patient outcome, but also their experience through the healthcare system and enhanced professional experiences as well. And hopefully more effective and more efficient care along the way through. And just as a side note, actually, in preparation for this, I was involved when they developed their care set for hip and knee osteoarthritis, particularly looking at outcomes after joint replacement surgery. But I note that they don't actually have outcome measures looking after fragility fractures, and particularly after hip fractures. So it might actually be an opportunity for FFN to collaborate with this group and raise the profile a little bit better, even still globally. So I'll come back to you about that for discussions, but it's a bit off the track for now. So next slide, thanks, Robin. So I guess we're setting the scene, burgeoning number of people, a tsunami of hip fractures coming. How can we deal with that in terms of trying to prevent them? And you'll always hear Paul Mitchell say, that 30% of the people who come with a hip fracture have told us they're coming, and so many of them are refractures. Part of what we did, and now just sort of sharing some of the evidence, as part of a number of different projects that I've led over many years, looking into this secondary prevention issue, we reviewed all the evidence that was available in reports, and sort of liaising with people internationally, saying, what's worked and what hasn't worked. And you can see there the sort of hierarchy of, type A, and that's the fracture liaison type service that we will espouse as the best possible model today, where you have a multidisciplinary team. They find or identify people who've had the fractures. They assess them and initiate a treatment, investigate and initiate treatment, and follow them up in a sort of one-stop service, if at all possible, addressing all of the comorbidities for that patient, addressing their social circumstances, trying to make a difference, all of which combines to help prevent that next fracture. And there are varying levels, right down to, probably something is better than nothing. And we kind of classified there at the bottom. Type D would be generally a letter, sent out to the general practitioner. Your patient's been through this hospital service, they've had a fracture. Could you please assess them and do something about their osteoporosis? And where that's been evaluated in different settings, sometimes it nudges up a little bit from 8 or less than 10% of people getting some assessment for their osteoporosis, maybe up to 20 or 30% of things happening down at that level. So something is better than nothing, but clearly we should all be aiming for type A if we can, where we see at least 80 to 90% of people getting some assessment, getting onto the treatment if they need it. So if we follow those sorts of programs, we know that we can prevent the next fragility fracture by around 50%, and that's through appropriate getting onto the appropriate anti-resorptive agents and adherence to that agents. But it's not just that, and it will vary a little bit by fracture type, but it's enhanced by the multidisciplinary team care, and a lot of that's around patient education and health professional education about the importance of self-management and lifestyle change, the importance of actually taking the medications. They only work if you take them, but also including there the falls prevention and strength training and resistance and balance and aerobic activity. So many things there, and again there's some evidence, some references for you to follow. So we know if we can get these people investigated and onto the right treatment and doing their exercises and other changes, that we can make a difference to reduce that risk of the next fracture. The other key thing in this is that it requires some different change in the way we do business. And I think, the evidence, the randomized controlled trials, they'll tell us that none of this will really happen without someone coordinating it all. So that need for the fracture liaison coordinator, and they play such a key role in this. And it's something that our administrators don't want to hear. They say, yes, the fractures are a big problem, and yes, you've got these medications and these things that can reduce the fracture. Well, it's a no-brainer, just do it. But we know from looking at that, you can't deliver that type A provide the top level of care without the fracture liaison coordinator that pulls it all together. And as I say, administrators don't like to hear that. So we have to sort of find additional evidence to show that we're making a difference. But a key thing with it is, and what something that Robin instigated for us here in New South Wales, that anyone with an interest in this area or who were already engaged as fracture liaison coordinators came together in a series of clinician training exercises, sort of learning totally different way of approaching things and that sort of healthcare and coaching approach, where it was more a partnership with the patients taking some learning what they needed to do, and then setting their own goals, or in collaboration with the health service to achieve those goals. And there's some nice quotes there with people very experienced and very excellent health professionals already really seeing how this type of health coaching and working with the patients to help them implement change in their lives could benefit things so greatly. But I guess there are so many obstacles as to, yes, this is the right thing to do. Whenever you sit and show some statistics to people in terms of the numbers of patients that are affected and how we could be able to make a difference, there are still so many obstacles, and perhaps that's we can share just a little bit with how we've tried to overcome some of them in New South Wales. But I guess all of this has to be adapted to your own local environment, and as we've acknowledged, clearly COVID is a considerable obstacle that we're facing. But I think we've got the community perceptions there that that it's just something of old age. We can't do anything about it. Have a hip fracture. Very high mortality rate following hip fracture. We can't do anything about that. And so, but I think clearly that message has got to get out there that we can do something about it. Even if someone who's had a hip fracture, if you do the right, put them through a system like that, you can prevent their next one, because they are at risk of a next one. But certainly earlier in the chain, we want to get people before they've had the hip fracture, and so we've got to get that clear message out. I guess we also have to get the message out that certainly what we've found in New South Wales when we've evaluated, but we've seen evidence for this around the world, that the adherence to the medicines is much better once people have been educated about it, but also when it's actually been initiated by the treating service. Because when people get out of the hospital care where all the specialists are, back into primary care, the primary care clinicians or general practice practitioners in our area tell us that, well, if you specialists in the hospital didn't think they needed this treatment, why would I, be wanting to start that? So that's got to be a collaboration. And looking at the different options. But the other key thing is also that respect for each other, that, I guess, fragility fractures are really everyone's problem, but no one's responsibility. And so because so many people need to look after them along the chain, everyone thinks maybe someone else will do it. So I think there's got to be, respect for the expertise of each discipline, the fracture liaison coordinator, which in our case could be a nurse or another allied health professional, such as a physiotherapist, but a respect for the orthopod, the medical specialists, the allied health, the nurses, and the general practitioner, that we've all, none of us could do this on our own. We all have to do it together, and we've all got a role to play. But the other key obstacle, obviously, is funding, and your sort of government and policy administration support. And I guess we'll try and show you a few ways that we've helped get around that. And I guess the other key obstacle, or something that can be solved, is the skill development. And Dave Marsh very nicely outlined some great work that the FFN is doing with their education models. And I think that's going to be more and more important to upskill everyone in terms of the education of knowledge around the treatment options and what can be done to prevent the next fracture. And also, as I mentioned, and the knowledge and the upskilling around helping people with their behaviour change. So I guess what we were lucky enough to end up with after a number of years, and I was proud to lead this work and couldn't have done it without Robin actually driving it all when she was the network manager for at the Agency for Clinical Innovation in New South Wales, and sort of her ongoing dedication to this is outstanding. And Erwin very nicely read out all those things that Robin's on now and doing for secondary prevention, but she's actually retired. So it's quite amazing, her ongoing commitment to it. But you can see there, we want that it to be a multidisciplinary team, and we want that to be, helping the patient and the family and their carers understand it. And Dave Marsh already says, that they've got carers modules as well, and just sort of getting that evidence across. And I guess we were fortunate in New South Wales that we had over many years been developing the model and reaching consensus amongst a whole multidisciplinary spectrum of clinicians and consumers that we developed it, and that we also implemented it in different settings, so in the rural setting and the regional setting and in our metropolitan settings. And we had some evaluation, we had consumer outcome measures, and we had some refracture prevention measures, and we were able to show some that it was cost effective. And Robin will obviously sort of tell you more about that shortly. So in terms of, how did we lead off with some of this? And it actually started back in 2009 when our network, got started. And perhaps this is available for you to do locally as well in your own hospital. We reviewed back over a 6-year period. We took a sort of cohort as best we could from the New South Wales Health data of inpatient statistic collection of who had been admitted with over the age of 50 with a fracture. And we had a list of fracture types, but the common ones: hip fracture, vertebral fracture, forearm fracture, humeral fracture, pelvic fracture. And then we tracked them as best we could over time if they had been readmitted over the next 6 years with another fracture, a fracture of a different type. So we identified at least sort of 5 to 7% per annum were being readmitted with another fracture. And so when we put all that stats together and worked out an average length of stay that those re-fractures had, it was something like 100,000 bed days. So we had what we called, what the New South Wales Health bureaucrats called a burning platform. So although we were saying all of this and all around the world, we've got this missed opportunity, others started to see that the data made a difference. And although we were still banging on a lot of doors, weren't we, Robin? But there was the surgical task force were concerned that the beds were all full of trauma and they couldn't do their elective surgery. So this was, elective coronary artery grafts, elective, hip replacements or knee replacements. So important elective, semi-elective, because people are only having it because they have a great need for it. But they were repeatedly having to cancel operations because the beds were full. And I know now that's also, they're full of other things. So it is still an issue with our COVID. But at the time, we then said, well, we have a solution for you. And we presented these data to say, look at all these bed days. Even if we could reduce them only by 5 or 10%, it will make an enormous difference to free them up for other things that you would like to do. And they started listening. So it was, we're all on this because we're all passionate about, osteoporotic fractures and the treatment and caring for those patients. But bureaucrats and people from other specialties don't see it. So we had to start showing things to them in their way of thinking. And so there we had our burning platform, as we called it. So we developed our model of care. It's a type A model of care. We drew enormously on the experience from the UK, particularly from Glasgow initially, but also enormously on what was coming from the wonderful work that Dave Marsh and others were doing with their hip fracture registries and outcomes, and shamelessly adopting what other people had done and then adapting it for our local environment. And that's certainly, you know, with all those toolkits now that have been developed, everyone should do that too. But I think, you know, lots of things were starting to line up and in terms of being in our favour, and we were very, very lucky that leading better value care focus was coming through too. And we had New South Wales Health has wonderful Secretary for Health, Elizabeth Coff, who initiated a leading better value care program. And so we're looking, you know, very positive outcomes for New South Wales Health. And, you know, we now, you know, have, as outlined in Robin's CV, that it's now a priority that everyone must implement it. And just as another thing running in parallel, and as a sort of perhaps a way that you could look in your own environment as to whether you can tag onto this, at a similar time, just really to address that enormous burden of hip fractures that we're all facing in our communities and our hospitals. Our Australian Commission for Safety and Quality in Healthcare were looking at their big ticket items, I guess the big things blocking bed or taking bed days in the hospital. And so they started looking at hip fracture care. And this little infographic, I guess I just draw you to the attention of the bottom right-hand corner on the screen. And it's a bit small, but essentially one of the key standards is a care plan for ongoing treatment and ways to prevent the next fracture. And if you can somehow get those sorts of things built into your care standards and general health care, so that means to do that properly, you have to have a fracture liaison service. So it sort of just makes fracture liaison services become mandatory. And obviously in New South Wales, actually, we call it osteoporosis refracture prevention because of that, you know, special meeting we had with the surgical task forces, and the leaders could accept that was the way to go. So I just share with you some of the background of how we got there, maybe some little tips for how you can gather your own burning platform, and also some support such as this, that it should be part of evidence-based best practice for anyone being admitted with a fragility fracture to also be moved forward with a care plan for stopping the next fracture. And I think it's over to you now. Thanks, Robin.
Thanks, Lynn. So I hope everyone can hear me. All right, so this slide here, I just wanted to add on from our model of care. This is the sort of interventions, the types of strategies that we have included in our model of care, so that we look at the person as a whole person. So they're coming to our service because they've had a fragility fracture, but in our efforts to diagnose and to investigate and determine what it is that they need for their ongoing care plan to prevent the next fracture, we need to incorporate some other activities so that we get the person or their carer or their family to be on side and know the importance of the need to improve their bone health. So I'm just going to draw your attention here, and I'm hoping you can see my mouse. So collaboration with general practice. We reiterate that every time we talk about this with our teams, is that this is just absolutely vital, that we as the fracture liaison service, identifying and supporting this person initially, we have to liaise and hand over to our general practice colleagues. So the general practitioner and the team that work with them, because of the tsunami that Lynn talks about, and because also most people really rely on their general practitioner as the source of all truth, it's really important that they are the ones that manage this in the long term. Of course, we ask our teams to touch base with the people that come through their service periodically, so that we can actually check in and make sure that what they're doing in their services is making a difference. But we don't encourage them as a group unless they've got special needs and really need to see a specialty service ongoing, that they come back to us regularly. The other thing is, and Lynn talked about this at length in the evidence review, patient reported outcomes and experience measures. So we've started to do that with our teams in New South Wales. helping them further understand what is important to that individual person or the person who's looking after them, so that we can incorporate what it is that's important to them within that care plan. It's not just about what we as clinicians say would be important to improve bone health. It's a team effect, and we've got to make sure that we include the person in all the decisions that we make. I'm also going to, I think I've got a slide around the personalised management plan that we've been developing up electronically. So I just want to talk a little bit now about who should be in this Fracture Liaison service team. And as Lynn said before, if we don't have a coordinator, we don't have a service. So that's your prime position that you must have to make this all work. Typically, in our setting, it's a senior nurse or a physiotherapist. I know in a lot of countries, it's always a nurse, but we've found that either a senior nurse or a senior physio. So ones that have got a lot of experience in the health system and with a variety of patients and disease groups and surgical groups, etc. So they have a really good understanding of our health system and also who turns up to our health system. But both of them, you know, over time work really well. So the nurse will have a lot of skills the physio won't have at the start and vice versa. But in sharing that through the peer mentoring that we conduct, they both come up as A1 practitioners. But we need them to bring everybody together, so that get the patients in, make sure the multidisciplinary team is there, that the services outside of our system are engaged and working with us collaboratively, and we work with them collaboratively. So there is that true team effect. So if we get down to what this person may do on the nitty-gritty, it would be around helping people understand the need, provide them with some health education and self-management support, but also do assessment on their bone health. One of the things that we find works so well, and their comorbidities, but works so well is if that team, as Lynn was talking about, really respects what each does and listens to what each does and finds and reports back. So that if we get to the stage where the person sees the medical person in the team, that the medical person doesn't have to go over old ground, that it's all there. It's all been assessed and reported by this expert nurse or expert physio, and you believe that, you understand that that's the state of the nation, and you can get on and do what you need to do around maybe some more investigation that only you can do, but certainly the prescribing. And then that means then you're freed up to see more people that, you know, of this tsunami that's upon us. They also need to be making sure that whilst they're looking at services that are out in the community, make sure that we've got a falls prevention service we can refer to, that there's, you know, there's availability there for the people to get into that service, because we find that very often they're overwhelmed, and so we need to advocate for them as well through our team, not just the coordinator but the team. And then make sure that everybody's on board with the same sort of documentation. So in New South Wales, we've recently developed an electronic medical record specifically for our fracture liaison services, our osteoporotic refracture prevention services. So everybody records their assessments and the interventions with the person in that same electronic medical record across New South Wales in our public health system. And so we can all see what we're each doing. It makes it much easier for patient management and continuity of care. And it also makes it much easier when we're looking at the data that we need for you know, the outcomes of our collective patient group, as well as our service reporting. Medical officer. Now I put here the medical officer is the champion of the service. And what we will often say is that the medical officer, who is the champion, the person who's more likely to be listened to by our funders, by our government, by our minister, whether we like it or not, they very often will ask the medical officer, what's the state of the nation? So they need to be the champion of the service. And then the other team members, the nurses and the allied health, often refer to them as the doers. So when we as a group decide that we need to do something in particular to make our service grow, to enhance our service, to improve the quality of our service, we as a group, including medical officers, nurses, allied health, consumers, administrators, evaluation people, etc., come together and make those decisions. It's often the nurses and the physios and other allied health that go out and actually do the nitty-gritty to make it happen. So we've got the champion medical officer, a very important aspect of setting up a fracture liaison service, as well as the doers. I think we've talked about the other allied health team members, but I want to bring your attention to the final point there around the administration officer. Very often that's missed out in all chronic disease services because it's seen as a luxury item. But my own personal experience and the experience of many others that we talk to say that as nurses and physios, if we don't have an admin officer, we would spend at least half our time doing admin duties. So if we've got an admin officer, we can get on with our clinical duties, with our service coordination duties, and thus more people can get to our service. So when we're looking at recruiting to this position of the fracture liaison coordinator, these are some of the things, the items that we would put in the position description, the call for what you need to demonstrate to get to the next level of interview. Now, some of these things, most of the applicants won't be demonstrating at a high level. So even though we say demonstrate at a high level, what I personally look for is that they've got an interest in each of those things. So they may have seen point number 1, 2, 3, 4, understanding of behaviour change strategies, and acute care clinician might say, well, what the heck is that? So I want to know that they've actually gone looking to find out what that might mean, and also be willing to learn more as time goes on. So right from day one in recruiting these people, they get to understand, well, this is your job. It's not just about clinical type things that we traditionally do. It's about understanding what the local policies are. You know, the local acute and chronic care policies. What are those policies for your state or your jurisdiction? Because you're going to have to build on those to get buy-in from the people that you're going to get funding from and sign off to recruit your team and to do the things that you want to do to try and prevent the next fracture. So I've just put in here some of the things that the fracture liaison coordinator will do. It's a little bit of a follow-up from previous slides, so I'm not going to go into them too much, but I've just put them there so that it keeps coming back to you when you look at these slides, what it is that we want your fracture liaison coordinator to do. They're not a glorified secretary, as I can see in some services. They are coordinators of care, they are clinicians, and they are expert clinicians. This slide's just to show you that when we sit around the table and try and talk about what it is we need to do to improve our services, these are the types of people that we need. So you've got your specialist doctor here, Professor March. You've got a couple of nurses. Here's a nurse, a physiotherapist. Up the back here, you've got our beautiful Jen, who was our evaluation person, giving us advice in that area. And we've got a leader from the primary health network representing GPs. Yeah, so you've got all these various people here sitting around the table and helping make the decisions on what it is we need to do next. But the fracture liaison coordinator needs to help get those people around the table. Now, I've just got a couple of slides here around some of the things that we've developed in New South Wales that support our teams in doing what they do, so they don't have to reinvent the wheel. And these are some of the things that we might be able to do across your region together in the next couple of years with a concept that I'm going to put to you right at the end. Certainly, you're going to have a model of care. You're going to have to be able to write up what it is, how you're going to practice, how your service is going to run, how you're going to access all the people that you need to run your service effectively. And you need a reporting structure. If you haven't got a reporting structure and it goes to your funders, the people that you report to, then your service doesn't exist. A lot of services or hospitals I've found is that they, the state has said, oh, you must have a osteoporotic refracture prevention service. So they'll recruit a coordinator and then just let them flounder. And so they don't have any reporting structure. They don't have any support structures behind them. So I just say to those people, well, you need to work with your local doctors and other team members, your manager, etc., to work up a reporting structure so that people know what it is you do and what sort of outcomes that you're getting. By having these two items happening in our state is how we became to have this as now policy, that you must implement a fracture liaison service. And these are just some of the things that we've been doing over time. And I'll leave you to read those in the interests of time. Now, personalised management plan, this is part of behaviour change. This is part of engaging the person, their family, their carer, in what I need to do to prevent my next fracture. So I'm going to determine with my clinician what it is that I need to do and what I can possibly do. It's okay for us as clinicians to say you must do, take these medicines, you must go to the falls prevention class, you must think about your nutrition, etc. That's overwhelming. It's overwhelming, and it's also, I've heard bad things about those medicines. And so we need to help them understand why they need to take those medicines as prescribed and long term, and go back to their GP or their specialist for rejigging of their plan of care. So then they then can then say, well, okay, so my goal is that I will take the medicines for the next 6 months and then I'll evaluate how I'm going. And so then the intervention will then be entered into in the lower part of the form. So it is that I'm going to actually make sure I've got prescriptions in my possession for the right meds, so I can go to the pharmacy and get the meds. And yes, I can get to the pharmacy. I'm going to report on here on my plan how confident I am at doing that, and I'm also going to put a target date. So it really engages that person in what it is that they need to do to improve their bone health. So this is in our electronic medical record. Everybody can see it. We share it with the primary care people. We share it with the person, obviously, gets a copy. It's there in our hospital-based electronic medical record. So we're all on the same page. We're all heading in the same direction and supporting that person in what they need to do. So just some educational opportunities. Dave's talked about some of these things already, so I've just put them here to, and I put them up locally to remind people about Capture the Fracture. Really great resource to make sure that your service is set up well. And you've got ticker box on the items that are really important. And also just recently they've published this patient level key performance indicators, which are a really good start for everybody in working out what sort of things do I need to report to alert my service that we exist and we're doing a really good job. We're seeing a lot of people, or we're seeing X number of people, and they've started their meds. I've checked 6 months later that they're still maintaining their medication adherence, etc., etc. So all the things that we know make a difference at the patient level in getting to the end goal of preventing the next fracture. Other educational opportunities available to you in your own region through the Osteoporosis Society. I've put in here Health Change Australia that we've used to help our clinicians understand how you speak to people, how you approach them to support them rather than tell them what to do, which many adults just don't respond to. It has a fee, and it can be used through the Health Change Australia online now. They've got an online modules, and I can support you with getting to these people and getting quotes from them if that's what you decide that you want to do. When they were doing face-to-face training, I found that only 2 days was needed to get to the stage of those statements that Lynn read out earlier around clinicians that have been working for a long time in the health system and not thinking, well, now what have I been doing all these years? in that I've been telling people what to do rather than engaging in their care. Now, the bottom point there is about peer mentoring across countries, facilitated by the Secondary Fragility Fracture Prevention Special Interest Group, who I'm representing today. And I've had talks with Erwin about this, and so we would like to continue that conversation of perhaps how that could happen in your region, ongoing, specifically addressing the issues that you would have in your countries. So what are your successes? How can we share those successes? What are your opportunities? What are your obstacles? And let's share those obstacles and talk about how others might have overcome them. Really great opportunity to come together and support each other to produce an A1 service. And some resources from FFN that Dave's already spoken about, so I won't go into those. So Lynn, you want to talk a little bit about the World Health Organization Decade of Healthy Aging, how that reflects for us in this work?
Yeah, thanks very much, Robin. Just very briefly, I guess one of the key aspects to point out is that the Bone and Joint Decade and now the Global Alliance for Musculoskeletal and Bone and Joint Health has been working with the WHO for 2 decades now, I guess. And they're a complex entity to work with and quite unique way of operating. And one of the I guess, the problems we face with this condition is that when the global burden of disease, people measure disease, osteoporosis is not a disease. Falls are measured and injuries are measured, but for the first time ever after considerable lobbying, low bone density was included as a risk factor for disease. So that was quite monumental, that now bureaucrats and policymakers and statisticians and people, non-medical people are seeing low bone density and therefore osteoporotic fracture as a problem. So that was kind of step one for them to even acknowledge that this is a health issue. But the other key thing about WHO is that they don't like to focus on the disease, but rather about healthy living and functioning and participation in life. And we became aware that, in fact, they were having the Decade of Healthy Aging, and they hadn't mentioned or even thought about musculoskeletal health. And so the Global Alliance, and I'm on that executive of the Global Alliance, got together with the European Union and actually funded a fellow, Andrew Briggs, an Australian physiotherapist and policy advisor, to work at the WHO to write some musculoskeletal components, including fragility fracture, into some of their background documents so that they became aware. So it's quite interesting, all the different avenues that you have to go to. But rest assured, we are working closely with, as best we can, with the Decade of Healthy Aging people as they roll it out in their initiatives, with their integrated care for older people, and also with the rehabilitation and disability task forces, wherever we can, mentioning particularly this problem of secondary fracture prevention, which ultimately will improve people's mobility. It's well documented, all the quality of life issues and impact on mobility and loss of function and loss of independence and loss of participation and quality of life. So sort of coming at that sort of more generic avenue that we will keep people moving if we can help prevent their next fracture. So that's work that's going on in the background. Thank you, Robin.
Okay, so some takeaway messages. In a previous life, I worked in cardiac rehabilitation, and you'll all know that that's accepted as usual business in healthcare. We need to get in early and prevent heart failure, for instance. So why aren't fracture liaison services accepted as the same to prevent the deadly hip fractures? So that's a conundrum for you, and a challenge for you in trying to get some highlighting and some extra funding to do what it is that you need to do. Heart failure services, which I was involved with in another life as well, are accepted as usual business. They aim to improve quality of life and keep people out of hospital. So why aren't hip fractures and their secondary prevention activities accepted as the same? So it's the same, for heart disease per se. So make sure also that when you build your business case or you're developing your model of care, that you align with the government and hospital agenda. So really look at what their policies are, what it is that they're aiming to do at the moment. We aligned ours with chronic care just because we knew there was a big push in our jurisdiction around chronic care, and our government had a particular way that they wanted to focus on it as well. So we tried to tick their boxes and get the buy-in. And it obviously worked because we're now part of normal care, usual business. And then if you can't get a government or on the government or hospital agenda, then try and align with a respected professional organisation. So you'll see in the UK that they've done that and still raising loud voices through that organisation. So there's just some things to think about when you consider, well, now how am I going to get them to listen? And I just wanted to put another word in finally about the special interest group. Everyone's welcome to join our group, and you just join it by going to the membership portal with the link that I've put at the bottom there. So, we share our experiences in our special interest group, successes and things that have concern to us, as I've spoken about before. Consider being a contact in your jurisdiction or your country, so that we can add you to our advisory group that meets 2 or 3 times a year, although it's a bit often at the moment because we're finalising a survey that's going to come out to you within the next 10 days. But usually it's a few times a year that we meet to actually plan our activities and decide who's going to do what and what we need to do, and particularly plan what we will do when the Global Congress comes around. But when you get this survey in your inbox in the next 10 days, if you're a member of the special interest group, you'll get this link to the survey. Please consider completing it. It is comprehensive. In trialling it with a few people, we've found that people who know secondary fracture prevention really well will complete it in about 20 minutes. But if you're a learner, you're a newbie to all this, it might take you longer. So some have said it's taken them 40 minutes to complete. But I urge you to please take the time, because this is going to be really rich data that we will have globally to determine what it is we need to do to move to the next level with supporting everyone in their secondary fracture prevention efforts. And if you can't get onto the membership area, or you just don't know how to do it, you can email me. Thank you so much. Thank you, Erwin.
Okay, thank you, Robin and Lynn, for that very comprehensive and very informative presentation. Okay, at this point, we want to call on KK, our FLS nurse specialist from Hong Kong, and Gio Rasalan afterwards, to give their views regarding the presentations. KK? Okay.
Thank you for the organizing committee to invite me to share my city, the development of the FLS service. Actually, in Hong Kong, the development of the FLS service is about, I think it's about 10 years and become progressively. And I think now we are almost in the type A model, as Lynn said. Yes, because in 10 years before, we call geriatric hip fracture. We have many patients. And at that time, we start to develop our service indicator. The first service indicator is the promotion and advocate of the shorten the period length of stay to decrease the post-op mortality and mobility. And then after that, we develop the service bit by bit. And now we have the fracture liaison nursing service or fracture liaison coordinator for about, I think it's about 6 to 7 years. And then I think it's about next year, most of the major hospitals in the public sectors have the fracture liaison coordinator. But we still have many challenges on developing on this service, because actually we have many workload, and because our healthcare system is much more similar to the Australia, and mostly is most of the patient is the public sector, and we have many patients, and that is mostly is by the government funded, so that we have many patients, and we also have some discharge problem after the hip fracture, but we are work very hard to overcome the challenge. And for this year, we have some new initiative. Is the developing of the day rehabilitative service is some kind of more systematic to treat the secondary fracture and prevention on the secondary fracture. Actually, it is a program and a service include the champion, the doctors, and also the nurses and the other health. And because now we still waiting of the approval from the head office through the annual bid, because in the last year we failed on the annual bid. But I think it is a challenge because because of the economic downturn, about I think it's the COVID, it's many countries and many cities as a tight budget, so that we will try our hard, we will try our best to establish for the service. And other very particular problem in Hong Kong is the venue, because it's a very small city, and so that on establishing on this new service, it is hard to find a venue in a hospital, and also for the manpower, because of the FLC already have a very heavy workload, so that we want to have more FLC to have this kind of day rehabilitative service and more systematic service on the prevention of the secondary fracture. And another kind of challenge is the training, because previously the nurses are appointed as a FLC, or we call FLN, fracture liaison nurse, also have very experience, and they have the experience on the orthopedics. They have very experience in the treating and care of the patient in the inpatient setting. But as Lynn said, because there is we need a behavior change training, it's very important, because no matter what is cardiac rehab or orthopedic rehab, because behavior change is very important for the outpatient. And for this aspect, it is lack of on the traditional or basic training. So that I think that for the FLC to have to do or to establish on this service, they need to have more knowledge and more experience on how to change the patient behavior, how to convince them. But luckily, we have opportunities, and we have good support from the multidisciplinary team, and no matter in our hospital level or in the among our orthopedic center, among the public hospital, we have a strong support from the medical doctors. So that I think, and also the allied health and the nursing, so that we have a good opportunity to develop of this, or further develop of this service in the future. And other I want to echo is that we have in this year, we try to develop our electronic medical record system, because in the past we also develop our have a data evaluation, service evaluation by the by manual to capture the data in every single center, and it is hard to merge the data and through the Hong Kong and develop and have a more service development and service evaluation throughout the Hong Kong. And in this year, we try to develop and we just start an electronic medical record system, and we have a common platform throughout all the public hospital, and so that we can have a service evaluation. And I would like to talk more about on the impact of the COVID-19, because on one side it is a very challenge because many patients cannot go in the hospital. Most of the outpatient service are suspended, and when the patient, if they need to go into the hospital, they need to have a screening of the COVID-19, and there are many administrative procedures. So, and now the outpatient service is progressively slowly resumed. And I see that there is an opportunities to develop a new service, because on the past few months, we start to develop some teleconsultation for the home assessment, because the patient, because the allied health or the nurses cannot go into the community to go to in the patient's home to have the home assessment. So that we start to develop the teleconsultation and for the education and also for the home assessment to prevent the secondary fall at home. Because from our data, the past data, and there is a proportion of patients have a secondary fall at home, especially in Hong Kong. The home environment is very tight, very small, and very tiny, and many other goods and easy to have a secondary fall. And we just start a project to evaluate the difference between the traditional phone follow-up and the teleconsultation. The results show that when using the Zoom consultation, we can pick up more risky factors that the patient does not perceive and cannot pick up in the phone consultation, so that we can position the Zoom consultation for home assessment as a quick screening tool. When we use an instrument, when we see there are plenty of the risky risk factors, we can identify, so that we can, and after the COVID-19, we can arrange the home assessment for the patient. So that I think the Zoom follow-up, Zoom consultation cannot replace the home visit, but we can help us to screen more potential high-risk case for the home assessment in the future. That's the end of my sharing. Thank you.
Okay, thank you, KK. Thanks for sharing your experience in Hong Kong. Yes, I think behavioral change is very important. No, we have to drive that into all the those who want to implement secondary fracture prevention programs in their respective countries. At this point, we may call on Gio Razalan to give his reflection.
Thank you, Dr. Tabu. Ili Razalan from Gerontology Nurses Association of the Philippines and Fragility Fracture Network Philippines. Good afternoon. First, allow me to express my congratulations to our keynote speakers for a job well done. I think that the keynote speakers, Professor Lynn March and Robin Spearin, covered very much of the larger perspectives and issues surrounding secondary fracture prevention in terms of scientific evidence, inputs on workforce development in its alignment with the decades of healthy aging. In relation to the discussion, several key points caught my eye and attention. First, I do agree with the emphasis of both speakers that behavior change must be central in any initiatives for a program to work and for a change to happen. I believe that a helpful approach is by exploring ambivalence with nurses. That is, by exploring the basic why. Why secondary fracture prevention is both personally and professionally relevant to nurses, and the benefits and rewards it can offer to older clients and the health system. Equally important is to explore on common barriers and consequences of failure to initiate secondary fracture prevention on the older person's quality of life, including the economic burden of fragility fracture. And by incorporating these aspects into each clinical contact with older adult client, this, I believe, can lead to behavior change and positive adaptation to change. Second, it has been highlighted by the speakers that secondary fracture prevention operates in a multidisciplinary team approach. This I considered both a challenge and opportunity in local context. It is a challenge because the real multidisciplinary team approach has not yet been well conceptualized in local practice. But this can be an eye-opener, an opportunity for the local practice to adopt and employ multidisciplinary collaboration, given its effectiveness in achieving positive patients' outcomes. Now, to scale up multidisciplinary team skills, therefore, training and development may be needed not only in behavior change, but also in interdisciplinary collaborative practice behaviors, such as effective communication and conflict resolution among team members. Third, because secondary fracture prevention is a multidisciplinary approach, a new vision of professional development is needed that enables learning both individually and from collaborative team perspective, and ensures that all health professionals involved in the fracture liaison service engage effectively in a process of lifelong learning, where mentoring and coaching program is a promising training and education approach. Fourth, I was thrilled and excited learning that in the developed countries, a nurse is commonly designated as fracture liaison coordinator. I see this as opportunity for lifelong learning. I'm thinking that this can be a direction in developing an advanced gerontology nursing specialty program on orthogeriatric with secondary fracture prevention as its core education, practice, and service component, and which will be aligned with the career progression path based on the Philippine Qualification Framework Professional Regulation Board of Nursing criteria, equivalent to Level 7 Clinical Gerontology Nurse Specialist. You know, after learning that such model of care has been implemented internationally over the past 15 to 20 years, I can't help but whisper to myself, what happened to us? Why we are left behind? The sad state in the Philippines is that we are not yet clinically implementing the models presented. So the challenge in our part is that we need to cope up, and we are not losing hope. The Gerontology Nurses Association of the Philippines and the Fragility Fracture Network Philippines are equally motivated to push a collaborative effort of implementing secondary fracture prevention initiatives. And now I feel absolutely optimistic when I saw all the models the keynote speakers have presented. As Dr. Tabo used to say, as I quote, with the aging population, we will be facing with an avalanche of fragility fracture. Thus, the time is now to clinically integrate such scientifically sound and evidence-based fracture liaison service without delay, and create and establish a local model of FLS care as pointed out by Speaker Robin. All of this can only be achieved through an integrated approach and interdisciplinary actions. In conclusion, I felt I've learned a great deal from this exercise. Now our focus is on what to do next, and to spend our energies on moving forward toward finding ways for clinical integration of secondary fracture prevention. As of the moment, initially I see the value of mentoring. Mentoring by our friends, our secondary fracture prevention experts in the Asia Pacific region as the most tangible, feasible learning opportunity in building dedicated fracture liaison service workforce in the country, a way contributing to the decade of healthy aging for the Filipino people and the people of Asia Pacific region. Back to you, Doc Tabo.
Thank you, Gio. Your remarks were music to my ears, actually. So I think that's the real purpose of this meeting, is really to encourage other associations, societies to embrace what we have been preaching with the Fragility Fracture Network, specifically with the secondary fracture prevention special interest group. So we look forward to more collaborations with the secondary fracture prevention special interest group, with Robin, and hopefully with the help of Lynn as well. Actually, yeah.
Excellent, excellent.
Yeah. Thank you. So it's not put into waste, or all that your presentations. We will surely really put it into, to keep the ball rolling here, at least in our country, and hopefully the rest of the Asia Pacific region. Thank you, Lynn.
Thank you.
Thank you, KK and Robin. Due to the interest of time, we have to move to the second part of the meeting, and hear the reactions from the leaders of the national FFNs and champions from the other countries in the Asia Pacific region. So I'd like to turn over the moderation and the chairmanship to the communications chair of the Fragility Fracture Network, and also a member of the steering committee group of the IOF Fracture Liaison Service, and also the program chairman of the Asia Pacific Fragility Fracture Alliance, Paul Mitchell, as well as to my colleague in the FFN board, Jeff Arbatin, who is instrumental in establishing the first fracture liaison service south of the Philippines in Cebu. So over to you, Paul and Jeff.
Thanks very much, Irwin. And look, it's lovely to see you all, and spectacular to see that we've had 230 people online tonight. That's absolutely superb. To Lynn, Robin, KK and Gio, inspirational talks. And thank you very, very much indeed. There's a huge amount of insight that you've provided to everyone. Now, my friends, because we have 35 minutes of this meeting left, we're going to have to work at rapid fire. We have 10 reactors who are going to comment back on what they've heard and how they can envisage workforce development going on in their countries. All of you could speak for 2 hours on this subject, so I'm going to be the world's most horrible chairman along with Jeff and say you've got 2 minutes. Right, and then we can have a bit of an open chat at the end. So we're going to do some very, very rapid introductions. I'll introduce the first bunch of folks, and we've got a ridiculously talented, committed and passionate group of people from Asia Pacific. So I think the region is in good hands. So to begin with, and it's lovely to see you, Jeff, in the time before we met in Seoul. Great to see you again. Fabulous. Yeah. So I'm going to invite first a dear friend of mine, Dr. JK Lee from Malaysia. JK has numerous job titles. He's a very busy man. He's the immediate past president of the ISCD, president of FFN Malaysia, vice president of the Osteoporosis Awareness Society of KL and Selangor, chair of the IOF's Asia Pacific and South Africa Regional Advisory Committee, and a co-chair of the Asia Pacific Fragility Fracture Alliance. So with that said, JK, what are you going to do in Malaysia, my friend? 2 minutes.
Yes, thanks, Paul, and thanks, Jeff. You can hear me. In these 2 minutes, I think I present how FFNM, what we have done. All right. One of the things that we actually have spent our time and efforts on this, developing a workforce here. And some has been done better, some are being done, and some will be done by FFNM over the next many years. And of course, basically, I think to start off the FLS in the country, we need a lead, or we call it champion. And of course, together with FLS coordinator or a team of FLS coordinators in the hospital. And with this lead and coordinator, of course, we had convinced the hospital management to allow us to do it, and to convince our colleagues, our surgeons, our physicians, to buy in the idea, the importance of FLS, allow us to kickstart the service at the hospital. Of course, work cannot be done without a team. So a team of surgeons, geriatrician physicians, anesthetists, radiologists, nursing, rehab, dietitian, and pharmacists are actually the members of FLS. And this whole program cannot be done by just 1 or 2 persons. We need a team, we need a family. And the formation of a team can be done simultaneously in multiple centers or hospital interested in FLS as a wide-based approach. And this is something contagious actually for a set of FLS. Once 1 or 2 centers setting up and actually spread it out, and it's actually, as I say, I use the word contagious, okay, for many, and to kickstart the service in different parts of the country. Of course, with that, you try to escalate to the healthcare authority and policymakers convert the fragility fracture care as one of the healthcare priority. And of course, very important, I think, over the past few years in this region, formation of society for fragility fractures are very, very important. With the passions, with the vision and mission, you can see that a lot of fragility fracture societies actually being set up, and we work together with all the other society, the geriatric, orthopedic, family physician, rehab, and so on, to even set up a national alliance, a regional alliance, global alliance with a stronger voice, and with one same heart and one voice. And we always believe that national alliance change the country, and regional global alliance change the world. Of course, I think we understand that there are carers, roles, and family members and so on, but patients. Now, a patient with a fragility fractures is the best person to talk to someone without a first fragility fractures, but at higher risk of fragility fractures, who might have a fragility fractures within the next 1 minute. So I think we forget about the patient themselves. Patient become the most powerful person and link to convince the public, her peers, her family, her members, and so on, that fragility fracture is important. FFS is actually very important. And of course, the role of media. Of course, all the meetings have been done on the virtual platform nowadays, but do not forget the local media, which is newspaper, TV, radios. They are very powerful for the local community. And a lot of times, that's the most direct first line that the people in the local community actually presented with all these ideas. So Fracture Liaison service should be introduced to the public through all this local media strongly, to remind them, rather than just, remember breast cancer, hypertension, and all the other things. And of course, lastly, the role of industrial partners, be it pharmaceutical or implant companies, could also be recognized in the process of building up this workforce in any regions of the world for promoting FLS effort. Thank you very much, Paul.
Beautiful. Thank you very much, JK. And I think JK there illustrates a really important point, is that amongst this group of enthusiasts, we can all inspire each other. We're not lone voices in the wilderness anymore, and we should all tap into each other and mentor, and seek mentorship from colleagues who have spent a lot of time working in big organizations like JK with ISCD. So fabulous suggestions, JK. Thanks a million. Rapid fire next up. Do we have my good friend, Professor Noriaki Yamamoto online? Noriaki, are you there from Niigata? Yes, he is. So very briefly, Professor Yamamoto is a board member of FFN Japan. Very importantly, he's the hospital director of Niigata Rehabilitation Hospital. So when Noriaki's gone to the boss to seek support for FLS, that's an interesting conversation, because he's talking to himself. And he's also been a member of the FLS Clinical Standards Group for Japan. Noriaki, over to you.
Yes, thank you, Chairman. I have a slide. Okay, today I'm going to about the Japan situation. As you know, Japan is super aging society. Over 65 years old population reached almost 30%. Recently, we have 200,000 hip fracture in Japan, and still increasing another 30 years. This is medical cost and hospitalization over 75 years old in Niigata Prefecture in my town. Surprisingly, fragility fracture is ranked the top of medical costs among other major diseases. Also, the reason of long-term care of the old people, first is dementia, second is a stroke, and the third is fragility fracture. 2015, Japanese Osteoporosis Society launched an educational program for osteoporosis. Now, 3,006 medical staff were certificated. 2019, Osteoporosis Society and FFNJ published clinical standards for FLS. This is IOF's best practice roadmap. 38 institutes joined this program from Japan. 2017, FFN Japan kicked off the National Hip Fracture Database to raise awareness for fragility fracture care. We developed hip fracture audit from minimum common data sets from FFN Global Special Interest Group. Now, 20 hospitals joined this project. See this slide, age of hip fracture last year, over 90 years old patient already exceeds 30%. Over 100 years old patients are not unusual in Japan. Japanese government focus on dementia and stroke for long-term care prevention policy. They have specific health care promotion. But now we need to establish new action plan for fragility fracture. Last month, we had an 8th annual meeting of FFN Japan. We invited officers from Ministry of Economy and Ministry of Healthcare to discuss for fragility fracture care service. Now we are going to make another relationship and organization. Thank you for attention.
That's a superb presentation, Noriaki. And I think for every minute I gave you to speak, you described 10,000 hours work. So thank you very much indeed for that. And yet again, as for other colleagues across the region, we're all at different stages of this. And friends, in FFN Japan was established in 2012. So Noriaki and colleagues have been at this a long time. And let's see after the meeting, Iwan, if we can facilitate a nice ongoing discussion between everyone. But that recent meeting with the colleagues from the Ministry of Health and Business, Economy, is incredibly important and a message to us all. Thank you so much. So next up, Professor Rajesh Malhotra. Rajesh, are you online? Not right now. Okay, Rajesh, if you're there and having computer issues, I promise we'll come back to you. So next, Dr. Mingwei Yang in Beijing. Mingwei, are you there?
Yeah.
Splendid. So Mingwei is General Secretary of FFN China and an associate consultant orthopedic surgeon at Beijing Juishui-Tan Hospital in Beijing and China. And Mingwei and his team have done utterly remarkable things to transform the care of fracture patients in Beijing at Juishui-Tan. Over to you, Mingwei. Give us an update from China.
Hi, everyone. I think although China is a big country, but very rare FLS was established in China now. I think the obstacles is orthogeriatric care was not established in most hospitals now. I think now most orthopedic surgeons, but some doctors, they don't know how to manage osteoporosis, or they are too busy to manage. And there's no good cooperation between the orthopedic surgeons and the endocrinologist. So, and also in most hospitals, there's no coordinators because our medical officer, they do not think this role is important. And not only at the hospital, also the money is a problem in China. So I think from our experience on the orthogeriatric care of geriatric hip fractures, we will find more local evidence to support the change. And we want to establish several models in China to gradually spread in other hospitals. I think this is the situation in China now.
Indeed. Thank you, Mingwei. I mean, to colleagues there, we can share after the meeting the work that Mingwei and colleagues did and published over the last 3 or 4 years. And it is quite remarkable when one looks at various clinical standards of care, whether it's time to surgery, whether it's osteoporosis and falls assessment, there is a point of inflection when the service started and the dramatic changes were achieved. So I think the combination of that work and the beautiful China National Fracture Study that other colleagues in China have done to characterize the epidemiology and the huge epidemiological burden will be transformative. Just to note that China National Fracture Study, one of the conclusions was China, like many other countries in Asia Pacific, had focused on road traffic accidents and other causes of injuries, but really omitted in policy fragility fractures and falls. That's fair to say, Mingwei, yes? And there seems to be a major move amongst policymakers to recognize that's got to change. So your work is tremendous and the potential for it is absolutely huge. So again, inspirational. Thank you, Mingwei. Now, next up, do we have Professor Sarath Lekamwasam from Sri Lanka online? Sarath, are you there?
Hi, I'm here.
Oh, beautiful. Splendid. Well, now, Sarath is the founder of FFN Sri Lanka and Professor of Medicine at the University of Ruhana in Sri Lanka, and has done some fabulous work around fragility fractures and hip fracture registries. Sarath, give us an update on what's occurring in Sri Lanka.
Hi. The fragility fracture work is progressing in different directions. And at the moment, what we are doing is actually consolidating our work and just to make sure that, we do some meaningful work. We are in the process of developing patient care pathways and get the approval of all stakeholders and particularly orthopedic surgeons for those patient care pathways. One of the main area that we are working on is to have early surgery, and at the moment there's a substantial delay in performing surgery, and only about, let's say, less than 20% patients are getting operated within 48 hours. So we want to make sure that surgeons surgeons adhere to this and then operate patients within short period of admission. The second thing is we are in the process of capacity building at the moment, and then this involves all the stakeholders and particularly in the allied health services program. And we recently had a workshop, and that is particular on allied health sciences people and on fragile fracture management issues. Certainly, COVID has retarded the progress of the work, but then despite that, we are trying to do some meaningful work with all the restrictions around. The other thing is that we are doing a gap analysis of our services, and then also trying to generate some evidence so that we have recently published hip fracture data, hip fracture rates, so national hip fracture rates in Sri Lanka. And also we have published mortality data, hip fracture patients, and also their disabilities. So we are tackling the issue in different directions. One is that trying to do a gap analysis and of the current situation, and also trying to generate some evidence so that we can speak to, when we speak to the healthcare professionals, that we have got some evidence under our belt, so that we can have a more meaningful discussion, and also trying to develop patient care pathways and get the approval of all stakeholders for those. So that's all. Thank you.
No, thank you very much, Sarath. And I think this issue of generating local data, local care gap analysis is so critical because information from other countries may be neglected and will be neglected oftentimes by local policymakers. So that's incredibly important work. Thank you very much, Sarath. So the final colleague that I have a pleasure of introducing is a dear friend, Dr. Tanawat Anfansap. Tanawat, are you there?
Yes. Hello,
Splendid.
Paul.
Lovely to speak to you, and I very much look forward to seeing you in Bangkok once all this craziness is over. So Tanawat is Chief of Osteoporosis and Geriatric Excellence Centre at the Orthopaedic Department of the Police General Hospital in Bangkok. Was one of the first people in Asia Pacific to establish a high-performing fracture liaison service, and he's the General Secretary of FFN Thailand, and he is the head of the Refracture Prevention Development Program of the Thai Osteoporosis Foundation. What's going on in Thailand, Tanawat?
Okay, thank you, Paul. So today I think we have 3 challenge issue in Thailand that I will tell you all. The first thing is about please, next slide, please. Okay, who is allow you to support building the case for change? So I think this is the first question that's really important. We had a multidisciplinary team for supporting the FLS program in Thailand, led by orthopedic surgeons. After admission, the FLS nurse identify a patient and coordinate a multidisciplinary team to ensure that patients receive bone mineral density testing, assess fracture and fall risk, and have education relating to nutrition, exercise, and fall prevention programs, and try to start orthopedic medication when follow up. Next please, okay. For evaluating and sustaining back slide please. For evaluating and sustaining FLS program, the top-down approach with a national health policy and national database registry are crucial, because the top-down planning work best when the organization needs high-level organizational change in response to outside threat and pressure. For this reason, the Minister of Public Health in Thailand took action since 2017. Okay, the second question is about the best option for patients and their family behavioral change. Quality and quality assurance are recommended as part of the service model. We have a FLS scan round every week to review and check our FLS process. and also educate the patient and their family before their discharge. And at first and third month, follow-up visits are conducted by a home visit team led by family doctor and nurse to assess the following aspect of care, and patients are appointed to complete at least 1 year follow-up at orthopedic clinic. In case the patient home is far from the hospital, they will be taken care by the nearby associated healthcare provider instead. And this process is a routine part of FLS care in Thailand without funding. And the third question is about what about team member training? Next page. We set up a fracture liaison service clinical practice guideline for doctor and clinical nurse practice guideline for nurse and member team, and organize many annual FLS forum and workshop for specialists and nurses that were certified and funded by Ministry of Public Health, Royal College of Orthopedic Society, and Thailand Orthopedic Foundation. As we know that since last year, COVID-19 pandemic situation has forbidden academic conference and workshop on orthopedics and FLS worldwide and also in Thailand. So we came up with an idea to create the first Thailand Bone Academy e-learning. The e-learning comprises of 24 academic topics from experts in orthopedics from Thailand. There are also pre-tests and post-tests on each topic and a certification of course completion. So that is all in Thailand for the last year and this year. Thank you, Paul.
Thank you, Thanawat. I mean, the work that's gone on in Thailand has been truly inspirational this last 3 or 4 years. I recall a meeting which had 50 hospitals, multidisciplinary teams up in Bangkok in 2017, I think it was, when the Ministry of Public Health made a commitment. And that's something that we should all really learn from. So thank you so much, Thanawat, for sharing that experience. I'm now going to hand over to Dr. Jeff Arbatan, my orthopedic colleague from the Philippines, from Cebu. Jeff, over to you to chair the second half.
Thanks, Paul. Great moderating. For the second half, we have a very good diverse group of speakers from various countries in Southeast Asia and Asia Pacific. I see Dr. Teo Kwok Leong from Hong Kong. Hey, hi, Dr. Teo Kwok Leong is an orthopedic surgeon and the coordinator of the Fragility Fracture team and leading surgeon of the FLS team in the Department of Orthopedics and Traumatology at the Queen Elizabeth Hospital in Hong Kong. Can you give us an update in Hong Kong?
Yes, maybe I will start with the healthcare system in Hong Kong first. Despite Hong Kong is a small space, we have around 8 million people. We are also one of the most aged population in the world. Every year we have about 7,000 hip fractures a year. In Hong Kong, the healthcare system a little bit more or less the same in the rest of the world, but 90% of patients requiring hospital care will be under the umbrella of hospital authority. So some of the previous study in Hong Kong saying that more than 98% of the patients suffering from hip fracture will be under our care, under the hospital authority, which is the only public hospital service centers. So we noticed that the group of researchers with passion noticed that there's a major issue in Hong Kong. So they back to 2012, a group of researchers with passion, they have a serious discussion and conferences with the stakeholder of the hospital authority. At that time, they start some workshop, a lot of discussion. And since 2012, we have got some money, some support, and some enhancement in the operation setting, the operation time arrangement, some inventory where we can treat the patient. At that time, we have reviewed some of the data at that time until we published a publication in 2015 saying that we need a standardized hip fracture pathways. So luckily, I'm working in clinical hospitals, and in 2015, we start a standardized clinical hip fracture pathway since 2015. Echo with Dr. Mr. KK Zhang said previously in his previous presentation, we start this pathway, standardized pathway with paper manual input. We have 40 pages of A4 size paper to input. In the past few years, our frontliner working people familiar with this paper, 40 pages, and then we changed to some web-based in the past few years. As mentioned with KK, since April this year, we just started kick off the app-based program for this pathway. We are looking forward in the future. We are going to work with our IT colleague. We are going to implement this fragility hip fracture pathway in our clinical management system. That means we are saying about 98% of hip fracture patients in the coming years will be included into this standardized pathway. We are saying about 7,000 hip fracture happen in Hong Kong a year. For the development of the FLS service in Hong Kong, we start to employ FLS since 2017. Currently, we have 6 FLN in Hong Kong. We start our FLS service in 2018, as echoed with Professor Lin and Robin, saying that we start our service in our hospital, Queen Elizabeth Hospital, with a standardized hip fracture protocol. And the FLS service is mandatory in my hospitals. So in the past few years, we have calculated we have taken care of more than 3,500 hip fracture patients. We are still currently have 1,000 patients under our care for the secondary fracture prevention program. So I think the development in Hong Kong in the diversity. We have 6 FLN in the future, presently, and in the future we have more. We have that diversity. In my hospital, we are using the hip fracture management to solve it. I know that somewhere in Hong Kong, the FLN start their service with vertebral fractures. But hopefully in the coming futures, with the establishment of the implementation of the standardized pathway into the computer management system, clinical management system in Hong Kong in the future, there will be more and more patients will be included in the program. That's all I want to share. Thank you.
Thank you, Dr. Leung. I like the transition, your progress from 40 pages to having a web-based to having an app. It really shows the importance of having a pathway and that all the patients, all the team members know where the patient is right now and what level of care should they be getting. Thank you very much.
Thank you.
Moving on to South Korea. Annyeonghaseyo. I'd like Professor Jae Yong Lim.
Thank you.
Yes. He's a professor of the Department of Rehabilitation Medicine, Seoul National University College of Medicine, and director of the Aging and Mobility Biophysics Lab of the Seoul National University Bundang Hospital. He is also a co-lead of the FLS Committee of the Korean Society for Bone and Mineral Research and the Vice President of FFN Korea. Go ahead, Professor Jae Yong Lim.
Yeah, thank you for your introduction. I'm going to talk about the secondary fracture prevention, building the workforce. Next, we are currently struggling to implement FLS to clinical practice and to disperse it to other institutions and other hospitals within our country. We have come to the consensus on the care pathway by multidisciplinary communication and have built an inspirational team. Also, we have a geriatric nurse care coordinator and clinical research team as core members. It is, I think, in the setting the role as a doer. Please back to the slide. Yeah. It is helpful to make a good partnership with Faculty of Nursing Academy. We continue to communicate one another and share the decisions for the patient care. Currently, FFN Korea is supporting multi-center observational trial for the effect of FLS, awareness of osteoporosis and its treatment improvement. At this time, 10 hospitals participate in this ongoing trial. Recently, government is trying to reform healthcare delivery system and promote regional collaboration between the regional center and public care clinics. Next, please. Here discharge care plan for facility fracture patients for nurse side and social worker side. This is a critical tool to share the core information for the patient and communicate with another. This year, we have started a new model of home-based medical care for facility fracture. The fees for education and discharge care plan and home-based monitoring, including telemonitoring, considering the current pandemic situation, are funded by National Health Insurance. Now this is a pilot project. As you may know, education and training members are fundamental and essential. FFN Korea is currently providing education and training program. FLS Coordinated Education Symposium was successfully held 4 times 2019. Back to the slide, please. This year, we have been grappling to maintain this as a virtual form. Our main challenges and barriers for the implementation of FLS. The first, as you may know, the more specialized care in each department, less coordinate with one another. Next, lack of awareness of FLS is both patient and family, and even healthcare professionals. These are main challenges and barriers in our healthcare system. On a positive note, we have started new project model funded by the National Health Insurance System and Insurance, which we will be able to support out of the hospital service, not just the hospital services, by multidisciplinary team, including home-based monitoring. Thank you.
Thank you, Professor Lim. What I really took out was basically the partnership of your FLS with the Nursing Academy and the social workers. And we look forward to your results of your pilot program. This COVID has really emphasized the use of telemedicine and how we can apply it into our FLS program. Okay, moving on. Next reactor would be Aisha Habib. Dr. Aisha Habib Khan is currently the head of the chemical pathology at Aga Khan University, Pakistan, and an assistant professor of the Department of Medicine and an International Osteoporosis Foundation Young Investigator Past Awardee. Go ahead, Dr.
All right. So right now I'm professor and a bone consultant at Aga Khan University. And thank you, Ivan and David, for providing me with this opportunity and a very promising, motivating, and interesting session currently it's going on. We have very different kind of problems in Pakistan, which cannot be compared with the established model of cares across the globe. And I strongly believe that the solutions have to be local in nature. As far as the public sector is concerned, there is very poor governance, with disintegrated primary, secondary, and tertiary care services, and poor communications between different disciplines. So developing a care model for secondary fracture prevention is next to impossible in the current scenario in the public sector. But the private sector has outgrown, and there are several networks that have evolved providing primary, secondary, and tertiary care services. And some of these are doing free of cost as well, and others at subsidized rates. So there are opportunities of implementing models in these setups to start with, and there's a way forward for implementation plan too. So we at Aga Khan University, we have been doing these efforts for the last 10 to 12 years now. And we have been able to engage different stakeholders. Several programs were conducted to educate for education purposes. And there's a special interest group from our musculoskeletal service line who is aligning things to start the FLS service. And we have produced local evidences highlighting gaps in patient care and audits against best IOF standards also. And there is evidence which has evolved and is evolving. But unfortunately, despite making everything available, we were not being able to execute the FLS model of care, the type A model that we are planning to, and we have agreement on the fracture pathway also. So a lot of effort has gone by, and one of the reasons, and I think is the biggest hurdle, is in getting funding for appointment of a coordinator and a medical officer champion. And we have tried several avenues, but it seems that our funders do not understand the concept of secondary fracture prevention, which is evident from the comments that we have received on our proposal. And getting support from the university or from the hospital is also, during these days of COVID, is very, difficult. So, and then there is the other reason is that everyone has so much in their plate that it is difficult to make out of it for the time being. So, but then we have hope that we will be, but everything is there and things have been sorted out. It's just, that we have to start this model of care. And from this session so far, what I have gathered, and I feel that a plan for the way forward is that David mentioned about a fellowship project. We have also developed a concept note on fellowship, and I think that this is an opportunity for us that we can liaise with the international colleagues and make a case taking our fellowship plan forward. And then secondly, what I have gathered is that there's a special support group that exists within the FFN network, and I'm thinking of engaging our group with this group so that maybe the people who are experts, they can give us a push forward for execution. And the third idea that has come in this session to me is the training of nurses and collaboration. I think we need to collaborate more with our School of Nursing, and maybe we can seek help from you as experts that how we can develop our nurse trainers and the model that can further give it a push to for execution. Lastly, the point, there is no professional organization who take responsibility for osteoporosis so far in Pakistan. We have done the baseline work, but again, we are looking for a corporate support or some support from somewhere to go through the legal processes. So there's a lot that needs to be done, but then the work is moving on, though at a slow pace. But an infrastructure and all the support, the family health education, the service, the departments are there, but then and to execute the type A FLS model will take some more time. And that's it from my side. Thank you.
Thank you, Dr. Habib. Coming also from a resource-limited country, it's great that you shine a light on our predicament. But from what I've heard and what I've been talking from this group really doesn't lack any human resources or any cooperation. So I think we can pivot the FFN to everybody chip in and help countries similar to us who are in the same predicament. Okay, moving on. Dr. Ana Gia Limpoco.
Hello, sir.
Hi, Dr.
Yes.
Dr. Ana Gia Limpoco is a consultant and an associate professor of the Department of Family and Community Medicine at the University of the Philippines, Philippine General Hospital. She is a member of the Board of Trustees of the Philippine Academy of Family Physicians and a chair of the Continuing Professional Development Committee. I'd like to welcome Dr. Ana Limpoco from the Philippines.
Yes. Hello. Good afternoon, everyone. Thank you, Dr. Jeff. So on my end, I just would like to highlight what are we doing right now. So after listening to all our esteemed speakers and all the reactors, yes, I think we have to start somewhere. And as you all know, we are a resource-limited country. And for my reaction, I would like to share what have we been doing in the Philippines, at least in our hospital setting. So I am part of the Department of Family and Community Medicine, Family Health Unit, and we have been part of the Fracture Liaison Service of the Philippine General Hospital. And we have the Osteoarthritis Multidisciplinary Clinic. So this is the OAMDC. And we get to look for and take care of patients with osteoarthritis of the hip and knee. This is being managed by the services of ortho, rehab, rheuma, and family medicine. And I would like to highlight that as part of the multidisciplinary team, next slide please, we want to provide a patient-centered, family-focused community care approach. That's our PFC. And why is that so important? Because we need to put premium on the training of our students and our residents so that after training, when they get to go to their areas of practice, they have this awareness and advocacy already in being able to identify and diagnose cases, not only of osteoarthritis, but osteoporosis as well, and identify the risk factors associated with this disease, recognize the biological, familial, psychosocial, cultural, and environmental factors affecting these patients. And what is important is really implementing promotive, preventive, and rehabilitative interventions for these patients. I also heard one of our speakers emphasizing on the need for tapping the family. I do agree. That's why we focus on really giving a family-focused care involving the family in the hope that we'll be able to assist and they will be allies in the care of our patients who are mostly in the aging population. And more importantly is collaborating with the other specialties and with the other societies, because we would want to highlight the importance of multidisciplinary interprofessional collaborations. and we want to reach the grassroots levels. We want the communities to be involved as well. And so we want a model like what we are doing, at least in our setting in the hospital. The OAMDCs, that's just one model that we are hoping that we can entice our colleagues to somehow create a similar one and apply it in their setting in the different parts of our country. So in that way, probably we can spread the awareness. We can provide relevant data so that we can use them as evidences that we can present to the policymakers so that they can give importance in terms of health care and service for our patients as well. So I think on our end, we're already starting. We have similar challenges as what I've heard with our fellow colleagues talking a while ago. And of course, we would always want to adopt what are the best practices and learn from countries who have already established these models of care for our patients. Again, highlighting the importance of a patient-centered, family-focused, community-oriented care. So I think that's it for my part. Thank you very much.
Thank you, Dr. Alimpoko. I really like what you did, wherein you piggyback, you couple, you package osteoarthritis with osteoporosis. It's basically building awareness and building on what is present and what is working. Next on, we have Dr. Derek Chan. Can you hear us?
Hi.
Hi, Dr. Derek Chan, rock star of osteoporosis. He's the co-chair of the Asia Pacific Fragility Fracture Alliance, the vice superintendent and executive director of the National Taiwan University Hinshu Hospital. Go ahead, Dr. Derek Chan.
Hi, everybody. Good afternoon. I'm actually in class right now, so I go out of my class. So it's a very sunny afternoon. Some update from Taiwan because of COVID-19. I think we do not succeed to getting the funding from the government to support the fracture liaison services. So on the other hand, we try to have other model to support our coordinators. What we do is that we try to work with the diabetes educator associations. We try to educate as many diabetic educators to know about osteoporosis care. So in that way, with diabetic patients, maybe we can create some smaller fracture liaison services within the endocrinology or primary care services. So it's our extension of some existing or some new fracture liaison services. But on the other hand, because of COVID-19, the total number of fracture liaison services in Taiwan have not been growing too much. Right now, we reach about 30 FLSs in this island. And then because of COVID-19, the existing services, they try very hard to make sure all the patients, they can get the medications they need. So for example, if they got a every 6 months medication, coordinators call them very hard to make sure they come back to get the injections. Because Taiwan right now, we do not have domestic cases of COVID-19. So we try to make all the service go back to normal. And then try to make sure all the fracture liaison service, they can run as smoothly as possible. And I think in the next year, maybe we have more time and more energy, we can try to develop more FLS in the future. Thank you very much.
Thank you, Dr. Derek Chan. It's interesting how you, despite the setback, you're able to reallocate your resources and keep your FLS intact. Thank you for taking time out to your class. Go back to your students. Thank you.
Thank you.
Our last speaker, our speaker in Myanmar is not available online. Our last speaker is from Nepal, Dr. Dipindra Pandey. Can you hear us? Yes.
Yes, sir. Yes, sir. I'm hearing you. First of all, I would like to thank you, everyone, for letting me in, because the country like ours cannot speak in this kind of forum. It's an opportunity for us. We established FFN Nepal, and we just started doing awareness about the fragility fractures and osteoporosis. People used to ignore these terms. I mean, even doctors used to ignore, but nowadays doctors are taking it very seriously. We didn't have any proper guidelines about the management. Then this organization called APCO, they developed guidelines. We disseminated it to the doctors of Nepal, and it was well accepted. And now we are following the same guidelines. Even the hospitals and doctors, they are taking interest in orthogeriatric care. The hospital where I work, we have started orthogeriatric ward, and we have also procured DEXA scan, which we didn't have before. And many hospitals, they have started procuring DEXA scan. FLS service has been installed due to COVID. It's very difficult to implement FLS amidst COVID pandemic. And another good thing is we are talking with policymakers, and one provincial government has committed, the minister has committed to implement some form of osteoporosis program from the next fiscal year in Nepal. That is very good news for us. The weakness of our country is we don't have our own fracs. So we are copying from Pakistan model. That is,
I think Dr. Pandey has some connection issues. Let's give him a time to re-log in. I think we'll give him time to re-log in. But what's really important is that he's trying to change behavior in his country by engaging the doctors and the nurses. It really takes software and hardware to facilitate this fracture fragility network liaison FLS service. We now have Dr. Tabu. Do you think we still have time for some question and answer?
Yeah, maybe a couple of questions, Jeff. I think we have some questions from our viewers. Maybe you can ask them already. We can address them to Lynn March and to Robin Spearin.
There's one question for Lynn March and Robin Spearin. There seems to be a disconnect between the falls prevention programs and the secondary fracture prevention in developing countries. Should efforts be made to bridge the two programs and provide a clear message to the community and the stakeholders?
I can lead off, but Robin, I'm sure, has got a lot to say as well. Yeah, it's very important that they're the same initiative, or they work together. And it is a key part of what our Fracture Liaison Coordinator does in terms of linking the people with the falls prevention services. And also, I guess, stimulated by COVID, we've developed some online exercises, falls prevention exercises that we've done in conjunction with our Australian Osteoporosis Bone Health Group and falls prevention people. So it's a critical element of the refracture, preventing the next fracture. So wherever possible, we've also tried to align falls prevention in some of the other strategies like cardiovascular health and diabetes health. And I liked what some people were saying there, that they're tagging on to other health initiatives rather than trying to reinvent new ones. That sort of every older person needs falls prevention and strength and balance for general health. Yeah. Do you want to comment, Robin? And I see Hannah nodding as well, so with her aged care hat on.
Yeah, I don't know that I've got much more to say, except that when you're setting up your service, that's a prime target of collaboration to make sure that you've got access there, and to work with them to make sure that they've got the resources to take on your patients, because it's, as many of you are saying, and Lynn's concurred, is that many older people need falls prevention services. So it's not just us that are seeking that collaboration. So banding all together with the other services to raise the flag that service really needs support and resources to make it happen for all these older people. The other thing is I guess you all know that there are questionnaire tools you can use to assess falls risk. So that's another opportunity that you can use within your services to make sure that you're capturing the right people, along with your own clinical assessment. Thank you.
Thanks, Robin. Okay. Another question here is that in low to middle income countries where resources are limited, it sometimes seems easier to get government support if we bundle up different diseases together in one health package. Have you come across this issue? And if so, what other diseases could we bundle up for fragility fractures without losing its importance and urgency? Is that possible?
Yep. So we actually tried that in a primary care initiative that we had running. So we tried to bundle up chronic care for people with osteoarthritis, along with people with fragility fractures and also people with low back pain. There were challenges, but I think it's very possible. And I think, you know, a dream that I've had for a long time is that we would have a chronic care service per se, and in that chronic care service you'd have all those disease represented. So, you know, diabetes, cardiology, chronic respiratory, musculoskeletal per se, and others. And so you would all bundle your resources together. So you'd get your equipment, your admin support, your venue, all that together, which would be very enticing in short funding situations. I mean, we have the same as well, but not as much as many of you. But I think that's a real opportunity for administrators to grab on. But you have to include in that model is that you would still have your people who know a lot about refracture prevention, a lot about OA, a lot about cardiology and COPD, etc., so that your patient still gets the best practice experts there. Sharing your allied health cohort as well. You know, that's often very difficult to get funding for allied health. They get funded for inpatient services, and then out of the goodness of their hearts, they come to the outpatient services like ours. But if they get called to go and see one pre-op, then your patients miss out. They're gone. So if we bundle things together, venue, admin, allied health teams coming together, we're more likely to get some funding, I think. Very attractive to the fund holders.
I think related to that,
certainly from Dr. Limpoco, that when combining the osteoarthritis model of care. So focus on bone and joint health for starting, I think would be very important.
Arvin, to share the idea of bundling different sort of diseases together. And what we have done in Malaysia, we have bundled different society together. And recently we launched an memorandum of understanding between the Malaysian Osteoporosis Society, Fragility Fracture Network of Malaysia, Osteoporosis Awareness Society of Kuala Lumpur and Selangor, which is a patient society. So all three of us are actually targeting the same objective. And the local funding company, they find, well, you know, there are three societies here, and which one you got to support is how much to support. So we actually bundled three together as a Bone Health Alliance of Malaysia, which actually launched recently. And we're actually sharing a lot of ideas and run programs together and directly targeted at the patient's level. We have done enough for the doctors and all this awareness, but patients public level. So we bundled three society as one Bone Health Alliance in Malaysia. And that helps a lot. And the company that's supporting is also very happy about it because they can support all three together as one. And that's another way.
It's a very good strategy.
Whatever way we do it, we need to just make sure you've got your experts there, because your patient deserves the expert knowledge. Yep.
Yeah, we have a message from Jackie, Jacqueline Close, that we have to be opportunistic of what's what's hot and what's really how people can buy in, as well as the government. So we just have to take advantage of what's popular as well. Okay, so there's maybe one more question. This is a very common question. How do you recruit fragility fracture patients into your FLS program? This is from Fedslin Johari. Okay. I think JK, you have a very good strategy in your hospital and how you
Yep.
recruit patients?
In my hospital, and we actually started. I'm practicing in a private hospital, so we had a criteria: 50 years and above, male, female, fall from standing height, usually considered fragile fractures. Once they get admitted, or they see an outpatient, or they're referred by the internal medicine, the colleagues and so on, we actually capture them into this program. And once the patients comes in, and how we started off was actually patient, we have a team in the hospital. So we actually informed all the team members using a WhatsApp sticker, snap pictures on that. So this patient admitted. So the FIS coordinator will mobilize and will see the patient and coordinate all the necessary things. So that's why you get all your fracture patient by either emergency department and also an internal referral by the physician. Patients see you as an outpatient clinic, orthopedic clinic, or GP referrals and so on. So once they have the criteria, you capture them in and recruit them and put them in the whole system, and then the whole thing runs. And we also do all different fractures, not the hip fractures alone, because private hospital, we do not really have big number of hip fractures in our hospital. So we also look at vertebral fractures, long bone fractures, collet fractures, and so on.
Thank you, JK. So I think due to time constraints, we have to end our Q&A. But I think Lynn has been kind enough. She has been kind enough to share her email address for any questions to you guys. I'm sure Robin and the rest of the FFN, FFN team will also be glad to answer your questions. Just direct it to our email address, and we will send them accordingly. Okay. With this, I want to introduce the president-elect of the Fragility Fracture Network Global to give the closing remarks. And after the closing remarks, just stay for 1 minute for a group picture. Okay, I just request to turn your slides. Professor Hannah Seymour from Australia as well. Hannah?
Thanks so much. And I think, look, Owen, I know how much work this has been for you and the team from FFN Philippines. So the first thing is really to say a massive thank you to you for organising this afternoon. I think it's been heartwarming to see how many people across Asia Pacific are managing to continue to do their best to care for patients despite the pandemic, and that we really are leaders in that multidisciplinary care and advocating for that across Asia Pacific. I think Jackie's mentioned a number of times, and I think what this afternoon's really emphasised is that it is so valuable to share knowledge from different places, but we do need local solutions, and we have to understand the systems of care locally in order to maximise the change within our own systems. But sharing this knowledge that we have together allows us to hopefully do that in a more effective way. I just wanted to really take another moment just to remind everybody that FFN exists and is a voluntary organisation with tight finances. And our global congress is a key way that we get income, and it's really, really important that we share and encourage our colleagues to attend the FFN Global Congress this year. It is virtual, so there are no travel costs that anyone needs. So we'd really encourage as many people as possible to register. We've got some excellent speakers. And it will be available, the recordings will be available if it doesn't quite work in your time zone. So really encourage people to advertise that locally and encourage people to register. Thanks again to everyone for attending this afternoon and for the effort being put into organising.
Thank you very much, Hannah. And we have time for a group picture. And with this, I also would like to invite everybody to the second pocket meeting on July, which we will do in collaboration with the Hip Fracture Audit Special Interest Group.
Yeah.
So I hope we will see you then in order for us to really have a full grasp of the multidisciplinary orthogeriatric and FLS advocacy that we are pushing. Okay, so may I request if you could open your videos for the group picture. Okay, Bernie, can you say if you've already taken the picture? Dr. Bernal Alpuerto, he's one of our, he has worked tirelessly
Hello, everyone.
To support okay.
I'll count to 3. Let's get this picture. 1, 2, 3. Smile, everyone. There you go. Another one. 1, 2, 3. There you go.
Okay. So with that, Thank you very much. And I hope everybody spends the rest of their weekend safely and keep safe. And although the pandemic is here, we can still push this advocacy, in our region, not only in our region, but in the rest of the world. So thank you very much and have a good day, everybody.
Thank you. Bye-bye.
Bye-bye.
Everyone.
Stay safe.
Bye-bye.
Thanks,
Bye-bye.
everyone. Bye.
Thank you.
Thank you, everyone.
Oh, well done, Owen. Fantastic work.
Bye-bye, Lynn. Thank
Bye.
you. Thank you very much.